Good afternoon, friends and colleagues.
So, you now.
We're going to move to the next live case session. The focus is on coronary bifurcation. My name is Ho Hee Hwa. I'm from Tan Tock Seng Hospital. Co-chairing this session is Dr. Michael Lee from Hong Kong. And this afternoon, we have a stellar panelists. We have Dr. Charles Chan, Dr. Chan Kam Tin from Hong Kong, Dr. Jose Nicholas Cruz from Philippines, Dr. Goh Yu Seong from Changi Hospital, Dr. Gautam Kumar from USA. We have Dr. Kwan Lee from USA, Dr. Patrick Lim from Khoo Teck Puat Hospital, Dr. Takashi Matsumoto from Japan, and Dr. Nam Manozaman. And our chat moderator is Dr. Pinakin. So we're going to go over to National Heart Center now, and the operators is Dr. Chin Chitang and Dr. Ho Kei Woon.
Hi, Hee Hwa. Can you hear us?
Yes, we can hear you.
Hi,
Hey, hi, Raffles.
Hi, I'm Kiwun, and this is Chi Tang. We'll go straight on to the case history. OB Van, we can switch over to the case history. We have a young lady, 56-year-old. If you can show the history. Yep. Long-standing diabetes for 20 years, on insulin for a brief period of time for about 5 years as well. History of gastritis, previous post-menstrual bleed. Quite a bit of significant cardiac history. She had previous chest pain. Initial maybe was negative. Then subsequently, maybe turned positive 2 years ago, mainly in the circ territory. She presented with unstable angina. EF was intact. Decision initially was for optimal medical therapy, but then she came symptomatic, and we did PCI to the circumflex, the drug-eluting stents as shown. Okay, next. These were the ECGs, no Q waves, EF is still intact. Next. And these were the blood tests. Renal function is creatinine of 60, HbA1c relatively well controlled 7. Next. Current medications, lots of diabetes medications. Next. And these were the baseline angiography. Remember, the circumflex have been treated.
Not yet. It's a pre-treatment.
Yeah, this was pre-treatment. Subsequent, the circumflex was treated. And we have the LAD, which we would see quite diffuse, small, and tortuous as well. Okay, maybe we can switch back to today's images. I'll bring you through to what we have. OB Van, we switch to the CAF. Okay, you can see the baseline angiogram that we did today, caudal shot, the circumflex is still patent. Left main eccentric lesion, you can see in the caudal view, actually not much of left main disease. The LAD starts actually proximally, is diffuse, and in the iliocranial, you can see eccentric calcification, proximal LAD, tortuosity of the LAD, and a few branches on the diagonal as well. Another angle, you can now appreciate distal left main, there's an eccentric calcification as well. The spider view, the distal left main is covered, but you can appreciate again the tortuosity as well as the diffuse nature in the LAD. So maybe we have an opinion from chair as well as the panel, what their treatment strategy would be.
Sorry, I forgot to introduce Dr. Eric Eckhart. So maybe Eric, you want to comment on the angiogram?
I've been talking already since this morning, so maybe ask the other panelists. But
Okay. Maybe we start from the extreme end. Patrick, you want to comment?
Hi, KK. Hey, hi, Chitang. Hi,
Hello.
Kei-woon.
Hey.
The left main, I think you were probably going to do some imaging, right? To see where to start and end. And then after you image the left main, then you decide where to stop. But it looks like very long, diffuse, tortuous disease, and then the shelf of calcium is quite nasty for you to do anything. So, yeah, but I think you can probably ignore the diagonal bifurcations because they're all quite small. And then the circ, I think you image first before you decide what to do.
Yeah, so obviously I agree with that. The distal left main needs to be sorted out.
And that can be done with either imaging or, FFR is difficult in the left main. You could try and use IFR with co-registration. The LED itself is very small. Even in the midsection, it's about 2 millimeters. I assume your guide is a 6 French. If that's a 7 French, then it's still close to 2 millimeters. Clearly, the exact burden of disease, atheroma burden, is important when it comes to sizing. I agree with Patrick that the diagonals you probably don't need to protect. They, by bifurcation arc criteria, they are supposed to be non-significant because they are so small. Yeah, that's probably how we would start.
Well, the LED is probably undersized,
Yeah, it's
so
probably
you want to like do some imaging, tries to ascertain the size of the LED. Yeah.
IVUS or OC?
You have some comments from Gautam?
Hi, Kevin and Chitang. This is Gautam. This is a very nice case, and really there's diffuse disease through the prox and mid-LED. I agree with all of the speakers before me that based on definition criteria, you probably don't need to worry about these branches. They're probably not significant at this point. I think it's really important to ascertain our landing zones in the LED to see what the significance is. I think IVUS is a very good option, or OCT, to also look at that distal left main.
Hi, Chitang and Kevin. Nice to meet you guys again. I think all the speakers has already voiced out most of the points, and nothing much to add. But since it's a bifurcation session, right? So we should try to protect the diagonals, you think?
Yeah.
Otherwise, there's nothing much to see.
Exactly.
Maybe the bifurcation is the left main.
Yeah. So those are exactly the same thoughts that we had. Okay, so this LED looks very unappetizing to me. It's very small, it's tortuous, there's some calcium in it, and the side branches are small as well. I take all your points about it not meeting definition criteria, but having said that, they are very small, and the caliber is small, but they supply a not insignificant territory. So quite a fair chunk of the LV, I think, is being supplied by those diacs, as well as especially that one that's kind of in the middle. So we may not want to upfront do something about it, but we would ideally not like to lose it. So that's the kind of thinking that we had. So let us maybe tell you what we did. So we have a 6 French system here, transradial, and we wired the LED. The LED actually wired quite easily. Then we tried to wire this diagonal. We thought it would be quite straightforward, but actually a little bit more tricky than we expected, because I think it does have a little bit of retroflexion, and that proximal LED kind of disease made it quite tricky to manipulate the wire. But somehow, luckily, by some luck, we managed to get the wire and the diag. And so, as you mentioned, we wanted to do some imaging. So we were going to put a OCT catheter down, but it kind of got stuck here. Yeah. So.
Wire closer?
Sorry?
I think your wire close, no? I mean, that's the reason the wire, the OCT can't go down, I think.
Yeah, so the OCT couldn't go down at this point. You can even see the catheter buckling a little bit there.
With this, would anybody change strategy, given that the imaging catheter that you want to couldn't go down? Would your immediate strategy change here?
I think you just take out the LED wire and then rewire again so that the wire will unwrap itself. The problem is that the 2 wire wrap.
Yep.
So that's why you got this problem.
Okay, so that was a Chitang's consideration as well, whether the wire did wrap. Any other thoughts?
I mean, one of the reasons why it can't go down, it could be there's some calcium or some tortuosity. I might want to test it out with a balloon, just an inflated balloon, just to test the path and decide what is the problem.
Or another strategy is that the main interest site is the distal lab main, the eccentric plaque. So, well, this is the, what is the IVUS? Is it a cerebral ultraview or Boston IVUS?
It's an OCT. It's a dragonfly.
Oh, sorry. Oh, this is OCT.
Yep.
But I'm not too sure. Well, you can change over to IVUS, for example, Navi Focus IVUS, Volcano IVUS. In case you cannot go into the LED, just have a glimpse at the distal lab main. I don't know whether it's sufficient for you to just have a look at the distal lab main, because that is the site that interests me most, all right? Because change our strategies and define our subsequent strategies. If there's the left main bifurcation disease, then maybe our strategy may be different, but just together with the LAD and the D1.
Yeah, so we take Hihua's point. We took a 2.0 balloon. It actually went past that bifurcation. It's not red, probably the calcification caused the problem with the OCT catheter. So we tried gentle inflation, dilated the mid part relatively well. Okay, we dilated further because I think we had another attempt to deliver the OCT catheter. All these were done with 2.0 balloon dilatation. With a little bit of struggle, we managed to get down the OCT and did an OCT run with co-registration. Okay, we don't have Chiang here, but we do have John, who is equally talented. Okay, well, no, yeah, so it's me. So we start from distal LED, as you can see, past the second diag. The vessel size is small. What we measured was less than 2 millimeters. Lots of dissection that we have caused with the 2 millimeter balloon from proximal to distal. A little bit of swirling of blood. We should be able to see the dissection here, and just now we saw a glimpse of the circumflex, and this is the left main. Sorry, that's the circumflex, and this is the left main. So maybe we go from proximal. This is left main. We are concerned about that eccentric calcification. Lumen size is still good, but you could see calcification about 1 to 3 o'clock before we come to the circumflex. Okay, if you can measure, yeah, so starting from proximal LAD, there is a possible relatively disease-free segment that we can land a stent. Proximal diameter about 2.5, whereas distal diameter less than 2 millimeter, about 38 millimeter length. Yeah. Any comments from experts of OCT? I'm sure everybody would be better than I am.
Yeah, Dr. Chan, does this help you, the distal left main?
Sorry, we missed it. What was the MLA of the distal left main?
It's about 6.8.
6.8.
Yeah.
So by definition, therefore, it's non-significant by imaging, which makes it isolated LAD disease in diffuse small vessel. I suppose one of the questions would be, would a DCB strategy here be acceptable, or are we all fully committed to place stents? So
with the dissection after the balloon dilatation, I'd be very uncomfortable just to do DB. You know what I mean?
Yeah.
Yeah, I agree with Prof. Chan as well. I think the issue there is with the significant dissection after the LAD, and you can actually see the dissection there angiographically as well.
Yep.
A DCB alone strategy may be a little problematic here.
can you do a hybrid, like half of it DCB and the proximal part where the dissection is worse, DES?
Yeah,
Or are you going to go, you know, with lots and
DCB
lots
just
of DES?
distal to the diagonal branch and then stent
Yeah.
proximal to it. Yeah.
Maybe instructive to go back to the OCT again to see beyond the diagonal whether there's much dissection.
Yeah, that's what I wanted to say. Also, very distal in the LED where the OCT catheter basically didn't go. There's this image that is not very pleasing.
Yeah.
There appears to be not much calcium, right, from mid to distal LAD, right, Kewin?
Yes,
Yeah.
and also not much dissection from the playback here. So a hybrid approach may be considered.
Yeah.
So small dissection, John is pointing out. This is beyond that diagonal, that second diagonal. Pointing out where the dissection is.
Yeah.
So leave this dissection, DCB, or stents the whole segment.
Yeah, I think like Charles said, like Prof. Chan said, I mean, we can't DCB the entire length, but you know, a hybrid approach is something that we were discussing just now as well. We don't really know how the mid to distal, the mid part is going to respond to further ballooning, but with the DCB. But I guess we can always bail out. The problem is, of course, the diameter. We're really restricted by how small this vessel is actually.
Yeah, we gave repeated nitro with the imaging runs, but so far distally we got it no bigger than 2 millimeters. It's about 1.8 diameter. So proximally we are getting about 25275. And length, possibly with a 38, we may cover from distal to proximal, relatively healthy tissue. Any suggestion from the panel what to do? Hybrid, one stent, what size of stent, and length?
Any comments, Dr. Cruz?
Okay, let's get
I think
the
we'll be happy with putting a
2038.
stent as long as you end up with a good expansion.
Yeah, so we think maybe we can put a 2038 that will go this past that second diagonal. It will land somewhere just after the ostium of the LAD. We are trying very hard not to touch the ostium of the LAD too much. So I think that's going to be our strategy unless someone feels very
Yeah,
strong.
Chitang,
Yeah.
any reason why you protect the first diagonal and you don't protect the second diagonal?
Yeah. Because I think the first one actually has more territory. Yeah. So yeah. So that really is the arbitrary decision point.
Anybody will prepare further? So far we have only dilated with 2O. We see lots of dissection on OCT. But we do see that it's highly calcified. We were quite happy, but anybody would have prepared further, approximately. Okay.
I think it's not too calcified though. I think even with the tool balloon, it opened up quite nicely with quite a lot of dissection already.
Yep.
I think it's ready to go with stenting. Now your stent is in.
Yeah. Very lucky actually.
Cheetah is skillful.
There's we were toying of, well, I wanted to show a modified gel balloon technique, but I think that would be pushing it too much. So I'm happy just to leave the wire in. I think
Chitang, your strategy is still provisional stenting.
it is still
Yeah,
provisional
okay.
stenting, yeah.
All right.
Yeah, that definitely. I mean, the diag is small, but there's no
Steep crane.
obvious stenosis or anything like that. Okay, let's have a small test. see
That's
where we are.
something I want to ask you, Chitang.
Yeah.
The modified gel balloon technique, we use it quite often with a very small balloon just to keep the patency of the side branch.
Yep.
So you decided not to go for modified gel balloon?
Yeah, because I think I don't want to make it more complex because I was worried about delivering this stent. I mean, we can try and deliver the balloon now, but I think that would just make it a bit more fiddly. Yeah. So I'm quite happy to just go with the traditional way of stenting across.
Maybe you take a picture and ask everybody about position. Maybe proximally. Distal we have room.
Distal?
We got room.
So you're going to stand the dissection first, right, Chitang?
Yeah.
Yeah.
So we come back a little bit.
Need to come back a bit?
This is a 38, I think.
Yeah, 38.
Okay, here we go.
Okay. Sit.
Try here. Maybe a little bit short, but I mean, I think
And
it's
always tack up distance.
yeah. I think it's better just to secure that proximal bit, then we have some freedom to do. Okay, you want to go spider just to check where we are? Just double check. Yeah.
Both caudal anyway. Both caudal. Spider may not see the ostium. Aria caudal. Or maybe towards AP caudal.
Most people okay with us leaving the left main alone, hopefully?
I think it's okay with the MLA above 6. I think most of us will leave it.
Yeah.
Would you consider leaving the stent distally and then putting a bigger stent proximally instead?
That's a good point, actually.
Well, we checked the expansion limit. So this is Science 2038. The expansion limit go up to 375. Yeah.
Okay, let's go. Yeah. I think
Flating?
my main issue is I want to see that distal LAD a bit better, and at the moment we haven't We're a bit ginger about injecting too hard. So let's tack this thing up. Okay, can we go up again?
Ready?
Yep. 12.
12.
Then once this is secured, I think we can have a better look at that distal LAD. A little bit concerned that maybe there was some further dissection that we didn't see. Go up again.
20.
Okay, down. Yeah, the other reason we don't want to touch that left main, if possible, is because the silk stent actually doesn't go to the proximal. So then we'll have to little dilemma about a little gap between the left main and the proximal silk stent. Okay, why don't we go areocranial?
Some nitro.
Yeah. Spider areocranial.
Nitro.
Okay, ready?
Great. Squid. Diagonal is.
Okay, the diagonal still there.
First one.
Okay, so shall we run another OCT and see whether we need to do more downstream? Shall we do it? No.
Okay.
And I suppose if we need to do something downstream, then this is where the DCB strategy could come in, perhaps.
I think it's not very often we implant a 2.0 stent in the prox LAD. I think we see this a lot, especially in the Southeast Asia. We have a high prevalence of diabetes. And so I don't know what about your experience in US and other countries. Do you implant a 2.038 in a prox LAD con or Gautam?
That's a great point, Hiwa. I think that would be very unusual in the United States to have a 2.0 stent in the proximal LAD. What about Kwan? What do you think?
Yeah, I mean, obviously we also have small Asian women and we also have small Hispanic women. And in those situations, sometimes you get to 2.0, but it's extremely unusual. I mean, so far they haven't post-dilated the proximal segments. Early on, the reference was 275. They just done the 2.0. So that proximal section should still be potted or post-dilated at the very least. So.
Yeah, no, absolutely right. I mean, I would shudder if someone told me to put in a 2.0 stent, the proximal LAD. But I think this lady's vessels are really very small. So we're trying to have a compromise between, overlapping stents, etc. And because of the expansion limits of this particular stent design, we're quite comfortable to go higher.
I have a question. This is a lady who kept on coming back for angina before, and is it worthwhile to do physiology in the distal LAD as well? Because this patient may come back again, and then the cause may be that distal LAD.
The distal LAD, don't know. Possibly we could consider that. Yeah, that's a great point actually. Yeah, I think previously the perfusion scan, most of the ischemia was in the silk type territory. So hopefully we get rid of that with the previous PCI. But that's a good point. So, okay.
So we had an OCT run. John is taking us through, but you can see from the longitudinal automated detection, it's white all the way until maybe about mid part and the proximal part, which we will optimize more. But so far, well opposed. Expansion more than 99%. This part in the mid part, unopposed. So proximally, we need to post dilate more, definitely. So we're going to do this with NC balloon, trio.
How about distally? Sorry, I wasn't paying attention.
This was right.
Distally?
All white color. White is good.
No, I mean post after the stent. After the stent. John, can you show us distal to the stent? Distal to the stent. There's no dissection down there. It's just, small lumen.
Just small
Yeah.
diffuse disease, I think.
Yeah, I don't think we can.
PO.
I think we're gonna leave it lah. I'm not sure how we can. Can we have that thing?
To also play devil's advocate, given Javier's lecture just before this, if we were to put an IFR wire down and do co-registration, and you found that there was no focal step up, it was just diffused all the way,
And see.
I suppose the question is, would it change your approach to this, where you simply medically manage that LAD and not stent it anymore? Like, if question to the rest of the panel, if you were to see that in a pullback, would it change what you do?
Mid part first. The diagonal go lower pressure 12 here.
I think based on what Javier told us just now, I think patients with diffuse CAD, they don't do well with PCI. So I think medical therapy would be a good option.
Go high pressure.
I think that's a fair statement.
Stem boost.
But you mean like
really
from the start
diffuse
we just medical treat this LAD?
No, I think the point Javier was making earlier was that
18.
now with pullback technology
Yep.
in physiology, we've divided our patients up into focal
Stent
disease or diffuse disease.
Stent boost.
And in this lady,
Yep.
the kind of pattern that one would expect probably would be diffuse disease.
Yep.
In which case, no matter how much you stent, your ultimate residual physiology at the end of the case is still likely to be ischemic. So, and they, the question though, is it a matter of, do people do better if you can move from say 0.3 to 0.6?
Yeah.
We do not know the answer to that question in 2022 yet.
Yeah.
But with,
20.
the courage trial and the ischemia trial at our heels, you have to ask that question in this specific patient. Maybe the answer for her in the future is a coronary sinus reducer. And not a,
I think the other way of looking at it, I mean, you have a diffuse small vessel disease. And I think with the current sort of FFR wire and so on, we can actually convert a long diffuse disease to spot stenting, So I think that's the other option of doing is like you do, instead of putting a long stent, which we know the long-term results not very good, is to do spot stenting.
So, Prof. Chan, would you consider this spot stenting?
I would first have some
Physiology.
yes, that's right.
Right,
yeah.
right.
So I think one of the things that is also there in the physiology data is that although we tend to use your IFR and FFR as a single number, it is not really a single number. There is actually a gradation of ischemia, even below 0.8, 0.8 to 0.9, 0.7 to 0.8, 0.6 to 0.7, and so on. And even if you can move the needle from, whatever that IFR might have been there, which is, I can bet you would be like 0.3 or 0.35, to now maybe what it is, which is probably like 0.5. I think there is going to be a benefit from patient symptoms. And then, I think Chi-Tang's hypothesis that you manage the rest of that diffuse disease distally medically, I think it's a very it's a very reasonable move to do that.
There's another thing that is quite striking. That is from the lateral view, the LED looks much bigger and longer than we think. If you compare frontal, the foreshortening with the lateral view, the wire is even not in the distal LED. Do you see that on the lateral view? So the LED is longer and bigger than we think, and the territory is potentially more ischemic.
It's a wraparound, I think. Chi-Tang, I think there is a focal lesion quite distal. So you might want to advance your wire and check it, because if there's a focal stenosis, I might be tempted to balloon it and treat it with a DCB. Yeah?
Okay, you mean distal to the bridging anterior? Not so, okay. I'm very...
Well, I think that our discussion is mainly a concept of functional guided by IFR or FFR versus the anatomical imaging guided, all right, by OCT or IFRS measuring the MLA. Right? I think for this particular long diffuse diseases, especially the patient got a Phaliums or the perfusion study, mainly focusing on the ischemia region in the left third, all right? After we fixing the left third, then I think it's still sensible to try the functional guided type of approach, all right? We put in a IFR, as most of the panelists have suggested, to have a good automatic pullback, co-register pullback, all right, to identify which exactly is the significant drop in the IFR, and then that may affect our strategies.
This segment is straightened up because it's soft right here, it's stiffer.
So, Hihua, do you see the angio just now? That's how the distal looks like. I'm still not tempted to touch it. I'm a very risk-averse person.
It's our risk manager.
Yep. So make sure we can see our stent. Okay, maybe somewhere here. Yeah.
Okay, sure. Okay, OCT.
Okay, I have to be upfront here. I don't use OCT a lot. So I think just now we were talking about, you know, OCT versus IVUS for this case. Do you think it would make any difference if we had done, it would have been better if we had used IVUS? I guess we've done 3 runs now with the OCT just to check the optimization of the stent.
So you post-dilate with a trio just now, is it, Chiteng?
That's right, just after the...
We can't hear you, sorry.
So sorry. Yeah, we use a trio just after the diagonal to post-dilate.
Can you hear us? Hello, testing. Can you hear us?
Can you hear us?
Some problems with the audio.
We can't hear the cath lab. Can we check on the connection?
Can you hear me now? Hello, testing. 1, 2. We have 15 minutes left. Testing. Hello. 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 Is it me you're looking for?
It looks okay, the stent position now.
Okay, we can hear you now.
Okay.
Hey, sorry, I don't know what happened there. Sounds like someone made a good joke and then we missed out here on the cath lab. Yeah, so that, okay, John, you want to just play the thing back? Thanks, John.
Yeah, so far the expansion looks good.
So I think it's around here that we went up with the 3-0 just after the diag.
Definitely a lot better opposed. And expanded.
Yep, so a little bit of gap before we get to the left main.
Yeah. Okay. Any comments about the OCT?
Actually, we wanted for you to go a bit more distally. There was a...
See the
after the last septal, yeah.
Yeah, okay. I can do that.
He was really almost at the end. The catheter was almost at the end of the wire. I can go a bit.
Yeah, I'm not sure I have enough length, Prof. You see the cone of the thing is... I don't really want to mess around too much with this small size LED.
Hi everyone, Pinakin here from the chat. I think I have no questions, but I mean, just ask the panelists, you know, after having done this, do you think we've rendered the vessel non-ischemic? Is it a good clear time to stop, or we pursue on with the distal work like, you know, OCT, IFR, or enough, and she should be okay? When do you stop?
Okay, all right.
I think, Pinakin, the key question here is that we don't have that information. You know, if we're going to say, hey, we're going to address the distal vessel, we're going to do something with the DCB,
Shall we
or
not?
I'm just hypothetically speaking, then you're going to have to get the functional data now with the post-PCI IFR or RFR or FFR, whatever it is, and then say, okay, I'm going to use this to guide the rest of my procedure. And that would be reasonable at this point as well.
Okay, we've used actually a fair amount of contrast already. So we're going to do one last OCT run to inspect that distal LAD. I suspect it's diffusely diseased, and I don't really want to touch it. The procedure has been thankfully quite boring, which is how I like it. So hopefully want to keep it boring. Okay, further, can I just have more slack, the OCT? Yeah.
A little bit more down distal, you're fine.
Okay,
right.
All right, I think should have just enough space. Okay, can you calibrate? Oh. Okay, test first. Okay.
Right, ready.
Oh. Okay, we got to do that again. Might have. No, I don't think. Yeah. Okay.
Let's see. Longitudinal view.
I don't think.
Can you flush your little
Yeah,
catheter?
yeah,
There's some blood in your line.
Yeah. I don't think we can.
Okay, all right. Okay, let's do this again.
put
Yeah,
your-
let's- Okay, ready.
Okay.
While we're waiting at Chiteng, I think it's a 1.5
steady.
that's so. I don't think you have a DEB that's 1.5, and then I think I will play devil's advocate. Doing an IFR, FLR will not change your management because you're not going to do more intervention on her.
Yeah. I think. I think. I tend to agree with you actually, Patrick. Yeah. But I mean, we've got the kit taken out already, so I think just spend a few mils of contrast, have a look at this distal thing, and then appreciate really how diffusely diseased and.
Maybe for ease of discussion, Nisha, can you help us co-register?
I think we face a lot of these problems when we treat patients with diabetes. So sometimes you have a very nice result proximal to mid, and then your distal, you just want to improve the flow. So in our experience in Tan Tock Seng, sometimes we use the smallest drug-coated balloon, like 1.5, because we are dealing with very small diffuse disease, and there are good data to support the use of DCB in small vessels like basket small too. So I think that is something that we all struggle with.
Yeah. But Hee-Hwa, you're a DCB expert. I'm not so expert. I'm scared I will dissect the thing. Okay, let's have a look and see what this piece of kit shows us. So while we're waiting, just to let you know, this is like a mini class reunion for quite a few of us here in this session. So it's nice. I wish I was actually at Raffles City and seeing you guys face to face.
Yu Xiong, Gautam.
So that's that spot lah. It's just fibrotic.
Maybe scroll back to that.
Yeah. Okay. I think
area
we've
of
seen all this
interest.
stent part before. Yeah.
So calcification.
Yeah.
Distal.
I don't know. I don't. What do you think, Hee-Hwa? You want to touch this with a DCB?
So you can use a 1.5/15 and then just see how it respond after your initial POBA for 20 seconds.
The main question is what happens if you dissect? What's the
Yeah.
I don't think you will. I think with Chiteng's hands, I think things are going very smoothly.
Okay.
Chiteng,
Yeah.
this is like the Kenny Rogers song, Chiteng, like the gambler, you gotta know when to hold them, know when to fold them.
Yeah.
Looks good.
I think I'm going to fold. But the point is well noted. Hee-Hwa, thanks very much for your advice. I will I will stop now, I think. We should learn to quit while we're ahead.
Wire trap.
So I'm going to take out the trap wire first. Hopefully there's no issue here. Okay, that's fine. So sorry, we really did want to show some, more bifurcation-y type thing, but
Sorry, Chi-Teng, do you have QFR in your lab? So that
yeah, we don't have it at the moment.
okay.
Yeah.
Well, because you got QFR, then it's very
right.
easy for us to assess that bit of the lesion without introducing all these IFR wire, pressure wire, etc.
Yeah. Maybe our aleocranials have a slightly different angle. I think it looks okay. We've managed to get away with doing this with both the diagonals still intact, even though we didn't protect the further distal diagonal. I feel a bit guilty about that, but yeah. I wanted to check. Actually, should have checked. But anyone would have kissed that that diag that we had the wire in?
No, I think the flow is good.
Yeah.
Small vessel, probably leave it alone.
Yeah. Yeah, I'm not a big fan of kissing. My wife will tell you that. So I think we'll just leave it. Okay, thank you very much. I think that's our case for today. And Kevin, you want to just maybe summarize and then give some learning points?
Yeah, I think today we showed a challenging case. Patient with diabetes is a typical kind of case that you will see small diffuse lesion across the whole diffuse LAD. We do see calcification and mixture of imaging as well as balloons to help us size and guide the stenting strategy. I hope this has been an educational session for everyone. Thanks everyone for your contribution.
Thank you, everyone.
Thank you.
Okay, thanks very much, Chi-Teng and Kei-Woon.
Okay.
Any final points from our panelists before we close today's session? Anybody has any comments to make?
Here are maybe just for discussion's sake, since you do so many DCBs, so if you are going to do this case, would you do a hybrid procedure, DCB of the distal and then the stent proximally?
Yeah, probably I'll try to do that. And sometimes I may just opt for a DCB-only approach if I have a good POBA result. Yeah, because we struggle a lot with diabetes, especially in our region. As you can see, almost every live case today has a history of diabetes. Yeah.
Do you have good results with this hybrid approach? We don't see huge data coming out from.
I think there is randomized control trial to support its use in small vessel. The biggest one is Basket Small 2. You have a 3-year follow-up that shows that it's as good as the stents actually. Yeah.
So Hiwa, coming from a part of the world where DCBs are not available and are under clinical trials, are there any specific tips or tricks that you would use or recommend or suggest in terms of utilizing these DCBs for small vessels?
I think the DCBs, the important thing is the lesion preparation. So it's mandatory for you to do a proper lesion prep. And if you have certain criteria where you have residual stenosis, 30% or less, Dimitri flow, and no high-grade dissection, then you can use the drug-coated balloon. I think there are a lot of very experienced operators within the region that are very highly experienced in DCB. Yeah.
Yes, Hiwa, just a follow-up question on DCB. You're so experienced in using DCB for non-left main bifurcation lesions. All right, you stand the professional stenting strategy. You stent the main trunk with the DES. How about any strategies of just doing the DCB to the side branch? All right, this sort of approach. Are you practicing it? In what sort of patient will you just stent the main trunk and then for non-left main, of course, and then DCB the side branch? And then do we have any data on that?
I think there's no very strong randomized control trial data for bifurcation because the approach is very heterogeneous. What you have been shown is that it does reduces the late lumen loss. And normally for myself, I will use DCB mainly for the side branch if I did any initial pre-dilatation, and I usually stent the main branch with the DES.
I have a small question for you too, because you may have seen single center non-controlled papers of DEB in high calcified lesion prepared at high pressure balloon inflation, even in big vessels, reporting not such bad outcomes, but this is single center, not controlled. What do you think about this strategy?
I think calcification is something that we all struggle with, and is a predictor of restenosis. I think when you use DCB in calcified vessels, it's important to do an extremely good lesion preparation. You need to use arterectomy or IVL to crack the plug. It's important to crack the plug so that when you deploy the DCB, the drug can diffuse into the media and adventitia and exert its anti-proliferative effect. That's how I feel when you use. But of course, we don't have any good long-term data for that.
Actually, some are actually doing rotablation followed by DCB. So would you recommend rotablation, DCB, and then?
There are actually two studies that's done, one in Finland and one in Japan, where they combine DCB with rotablation, and the MACE rates ranges from 10 to 20%. So it just tells you that calcified lesions are the most difficult to treat. In my opinion, it's very difficult to treat. So the case before this, the live case, you can see KKO trying all means to get a good lumen gain, and whether you put in a stent at the end is also something that we all struggle with, because if you put in a stent, you have an underexpanded stent, is also a nightmare for the patient and for the doctors. Yeah.
In some of the cases that we've seen in late follow-up angiography, there's actually been lumen gain for some of the areas that were treated with DCBs. Is that a phenomenon that you're seeing as well, especially in this small vessel disease?
I think for positive remodeling, I think so far the paper by Professor Kleber shows that for his series of 70 patients, positive remodeling is observed in about 70% of patients. But from our real-world experience, I think probably less than 50%. Yeah. So I think it's time to wrap up. Hope you all had a good session on coronary bifurcation. I think congrats to the National Heart Center team for showing a nice approach where you keep things simple. And thank you to all our panelists and the comments. Thank you very much.